Kia ora everyone. Welcome to this Goodfellow Unit Webinar on optimizing management of female urinary incontinence. This webinar is kindly supported by ACC and the Ministry of Health. With us tonight are 4 speakers. We're lucky enough to have Dr. Niki Dykes come back, who is an obstetrician and specialist urogynecologist at Te Whatuora Waitemata. Also Dr. Samsom Low, who is a consultant urologist at Te Whatuora Waitemata, and Helen Peake, who is a continence nurse specialist at Te Whatuora Southern. And we also have Shelley Solomon, who's a pelvic health physiotherapist in Whangarei. Welcome, guys, and thank you for coming along. So I'm going to hand over now to Niki, who's going to start the presentation. Thanks, Niki.
So thank you very much for having us to speak tonight. We're talking about optimising management of female urinary incontinence, really focusing on conservative management strategies. We'd just like to say, if you do have any particular case studies or anonymised patient questions that you wanted to ask, the panel at the end of this session would be very happy to kind of answer some questions along those veins. So the background to this, some of you may have attended the webinar that Samsom and I gave a few weeks back on management of mesh complications. This is part of the same kind of education package that through ACC and the Ministry of Health we're creating for primary healthcare providers. And the background to this was the Restorative Justice Report, which was published by the Ministry of Health in 2019, entitled Hearing and Responding to the Stories of Survivors of Surgical Mesh. And this presented the negative impacts that mesh has had on the lives of many New Zealanders and their whānau, and outlined a series of proposed actions in order to repair harm, restore wellbeing, and ensure patient safety. So this is the interdisciplinary education that we're kind of working on within our group. So female urinary incontinence is a really common problem. We know that lower urinary tract symptoms are extremely common in women. This graph here shows a study that looked at kind of more than 30,000 men and women over the age of 40 years from USA, UK, and Sweden. This graph just shows the prevalence of lower urinary tract symptoms and associated bother in women. And you can see that there's the one that I've circled there is stress incontinence. So almost 35% of the women studied had significant prevalence or significant bother from stress incontinence in this study. So it's a very common problem. This graph quite nicely shows the kind of prevalence of urinary incontinence subtypes over time in women. So when women are younger, there's a fairly low prevalence, and as women get older, there is a much higher prevalence. You can see that stress incontinence, which is the red line on the bottom of the graph, that actually has the most highest prevalence kind of in about the 5th decade and then tends to drop off, whereas urge incontinence and mixed incontinence both increase with time. And this shows actually very high prevalence, at kind of close to 50% of kind of 80, 90-year-olds may be experiencing urinary urge incontinence, so very common. In terms of kind of New Zealand prevalences, we don't really know exactly the differences in prevalence. This is a study from 1994. It was a postal questionnaire. About just over 1,000 women were randomly selected from an electoral roll in Wellington and sent a questionnaire. And they found that the prevalence of urinary incontinence was actually really high, particularly in Māori women. Almost 50% of women had urinary incontinence. As expected, there was an increased prevalence with increasing age and parity. And almost 1/3 of women reported urinary incontinence once or more daily. Now, there may be a bit of kind of selection bias in women who've responded to this questionnaire, but it kind of highlights how prevalent this condition probably is. Of interest from this study, only 1/3 of women who reported incontinence had actually sought medical assistance. At least half of women did want medical help, but many women actually thought that this was just a normal part of aging. So it really kind of highlights that it's prevalent. Women may think it's normal and therefore not actually seek treatment for it. So in terms of the types of urinary incontinence, we're mostly going to be focusing today on stress, urge, and mixed urinary incontinence. So the International Continence Society definitions of these, so the stress incontinence is the involuntary loss of urine on effort or physical exertion, including sporting activities or on sneezing and coughing. And this usually relates to kind of urethral sphincter dysfunction or loss of bladder neck support, which we'll cover in this talk. Urge urinary incontinence is involuntary leakage associated with the sensation of a sudden or compelling desire to void, and this is idiopathic or neurogenic. And mixed incontinence is when a patient has both stress and urgency urinary incontinence. Now, other things that we're not going to be talking about in detail tonight, which don't come up so commonly, are overflow incontinence. So this is incontinence in the presence of an excessively full bladder, and that can relate to a hypotonic detrusor, so a bladder muscle that just doesn't squeeze effectively to empty, or if there's urethral obstruction, so a prolapse may be creating an obstruction or previous incontinence surgery. And then there's other conditions that can occur, so fistula, nocturnal enuresis, or coital incontinence, or all other types of incontinence that we can manage.
This is just a really good diagram to look at how stress incontinence relates to urge incontinence. So if you look at this diagram, we often see patients that has pure stress incontinence, which is on the left side of the diagram. But often patients could present with some urgency or overactive bladder symptoms, but they are not really wet from having urge incontinence. So there's a lot of crossover between what we call dry OAB, meaning not really leaking from the overactive bladder symptoms, to people who actually has got incontinence from their overactive bladder. So you may see this range of patients already, but this is just a good diagram to see how they all relate to each other. So when we talk about incontinence, the way we like to sort of put it into groups would be to look at bladder factors versus outlet factors. So in terms of bladder factors that can cause problems with incontinence, if you think about overactivity, which I've just talked about, generally patients like to ask this question: why do I have urge incontinence? Why do I leak with urgency? 80% of the time, there is no easy answer. So 80% is idiopathic. So that's what I talk to most patients who are fit and well with no other medical problems. It is something that they've developed over time. And out of that 20% that is not within that group, if patient has got a background of a known neurologic disorder, for instance, multiple sclerosis or Parkinson's, or they've had a spinal injury, then again, they fall into the group like we like to call neurogenic cause. I just want to highlight one out of the many that I've put down there, that if you can't categorize them between a neurogenic or idiopathic, then the next most common ones that you would see would be bladder outlet obstruction. Now, most of you would see both male and female patients. So you would know very well for male patients, for instance, if they have had a big prostate, they've had poor flow, and then they develop urgency, frequency and urgency, that's a cause of their overactive bladder. So same for female. So if you feel like this could be an obstructive cause, it's not very common for females to have obstructive causes, but the most common thing that, from listening to our webinars would be to look at whether they've had previous anti-incontinence surgery. So if they had a sling, whether it's mesh or non-mesh, if they had that being pulled too tight, they develop bladder outlet obstruction, then that can cause a worsening of the overactivity or a new onset of overactivity. Now, don't want to go too much into problems with compliance, but basically compliance just means that the bladder is not so stretchable. So for whatever reason, the bladder has become like a leather bag, they're no longer stretchable. That can cause problems with incontinence. And the most common thing that you would see in your practice would be patients that has, say, radiation treatment, pelvic radiation. The bladder has been radiated, and therefore it doesn't stretch as well as a normal bladder. Again, a combination of all of these could cause problems with storage due to their bladder problems. So this slide shows, what about the outlet factors? So if their bladder has no problems, what can cause incontinence? So in terms of the stress incontinence that we see a lot in female, the two commonest causes would be urethral hypermobility or intrinsic sphincter deficiency. You don't need to know the details of this, but basically, if it's a problem with the urethra being very hypermobile, it is generally due to the lack of support around the urethra. And there are many different structures, ligaments, muscles that can cause this. But generally speaking, it is the support around the urethra that's actually been either weakened or damaged that's caused stress incontinence. or if it's more of a sphincter issue. So the sphincter itself has been injured either by us removing mesh, for instance, or patient that has got multiple system atrophy, so a neurologic condition that's caused the sphincter to not coordinate with how the bladder empties, can cause this problem. Now, again, a combination of both is very common, so most patients would have some urethral hypermobility and some intrinsic sphincter deficiency to cause stress incontinence. Now, fistula, it is a storage problem, so they're not being able to store because the urine keeps leaking between the two structures. So fistula can be the abnormal connection between the bladder and the vagina, called vesicovaginal fistula, or it could be a connection between the urethra and the vagina, called urethral vaginal fistula. So I don't want to go too much into that, but that's definitely something that you would see patients having continuous incontinence. So it's not dependent on cough or urge, they just leak all the time. Now, there's a huge list on the risk factors for urinary incontinence. Later on, when Shelley and Helen goes through their slides, they'll go into a little bit more detail on this, but basically older people do have a high risk. A patient that has had multiple pregnancies and aspects of their delivery that's caused loss of tissue or urethral hypermobility because of the structure around the urethra has been stretched. Obviously, more bigger babies, more multiple pregnancies can increase the risk. And other things that are more sort of that we want you to be paying more attention to is their lifestyle. So obesity, smoking, and their diet, and certain medical conditions increase the risk of urinary incontinence.
So we'll just talk now a little bit about kind of assessment of incontinence in terms of what to be looking at or asking when you're taking a history from a patient. So we're really, when you're taking a history from a patient, it's really helpful to ask them or try and establish what kind of type of incontinence they have. So really identifying, are they leaking in association with stress incontinence, so with coughing, sneezing, moving, lifting, exercise? Are they leaking in association with a feeling of urgency? So are they getting that real feeling of, oh, I've got to go, and they just can't get to the toilet in time? Assessing severity is also quite useful. So trying to establish kind of how many pads they might go through in a day. Are they needing to change their clothes? Sometimes women don't really, again, volunteer this. They'll say, oh, my bladder's okay. And you find out they're going through a pack of pads a day. So it is can actually be a lot more of a problem than women may kind of let on. Associated storage symptoms, it's always useful to ask about frequency, urgency, and nocturia, which are all kind of part of that overactive bladder syndrome. Any voiding symptoms, so any difficulty passing urine, any kind of needing to strain to void, any kind of need to double void, position changes, anything like that can be useful information. And if there's a history of recurrent UTIs, it can sometimes also be associated with someone who is incompletely emptying their bladder. Any pain or hematuria, again, are kind of red flags. It could be a bladder infection, but you'd also need to think, is there something else going on? Could it be a marker for bladder cancer? Is it, what else is going on? Assessment of fluid intake is also quite useful. Sometimes we see women who have quite significant urgency, frequency, incontinence, and you find they're drinking kind of 4 litres of fluid a day, and a lot of that might be caffeine. And so sometimes just getting a bit of an overview, what have you had to drink today, can be quite helpful, just to try and establish there might be some quite simple things that you can initiate straight away in terms of some simple lifestyle advice that might be helpful for them. Any history of previous treatment for incontinence or prolapse, it's really useful information. So particularly if they've had any mesh surgery, but also if they've had kind of a Birch-Culper suspension, which is an incontinence surgery, or even any conservative treatment, it's really useful getting that information. And again, if they do volunteer that they have had a mesh procedure and they're coming to you with incontinence, that would be kind of a sign that or a marker for them that they need to be referred through for us to see them. I know that you have limited time when you're seeing a patient, but sometimes if you did have time to ask about kind of prolapse symptoms, bowel symptoms, and sexual dysfunction, these often all go together. There's often not just one problem, there can be several, and even just kind of getting that history so that when you refer through to someone, all that information is available can be really useful for us. And any relevant medications, so patients who are on diuretic medications, medications that stimulate a cough, anything like that is quite useful information to gather from the history. So on examination, some things that we kind of often look at are, and I'm sure you do too, in terms of level of cognition, mobility. And sometimes if someone is quite limited mobility as they get older and they have significant urge incontinence or nocturia, maybe just simple things like having a commode near to the bed can be helpful. So really just kind of that can be something you could be thinking about just in watching them walk within your room. An abdominal examination, feeling for a mass, a pelvic mass, a full bladder. And in terms of kind of having a look down below, I know sometimes it can be a bit daunting if you're not quite sure exactly what you should be looking for in someone who comes for incontinence, but really just having a look can be really useful because there might actually be some things that you kind of go, oh, that doesn't quite look right, which can be helpful information for us if you're referring through. So vulval skin changes. Sometimes you'll see women who have terrible excoriation from urinary incontinence or kind of contact dermatitis from the pads that they're wearing. And so maybe starting to think about initiating a barrier cream could be useful. Signs of vaginal atrophy. So many postmenopausal women will have atrophy, and that's something that you can treat quite easily with estrogen cream. But kind of knowing that it's there would kind of then prompt you to think about whether that is going to help with some of their incontinence, and we'll kind of come back to that. With prolapse assessment, we would usually or often use a speculum, but you don't need to. And I think a simple way to try and assess if there's any kind of prolapse or incontinence would be to kind of part the labia with one hand, ask the woman to kind of bear down, to strain, ideally for at least kind of 6 seconds. Studies have shown you need a good 6 seconds of straining for you to be able to see kind of the maximal degree of prolapse. And what we really are looking for is where is the prolapse coming to in relationship to the hymen? So is there a bulge, but it's inside the vagina? Is it coming to the entrance? Is it actually coming kind of 5 centimeters outside? And actually kind of making note of where that most prominent part of the prolapse is really helpful, particularly if you're referring through for us to see, because it helps us triage appropriately. It doesn't really matter which part of the vagina is coming down. And if you're not sure, it probably doesn't matter too much, but just kind of saying it's coming to 5 centimeters beyond the introitus, that's really useful information. And sometimes I sometimes find that patients, you ask them to Valsalva and they can't, and sometimes they're actually kind of squeezing everything up inside. So sometimes asking these women to relax and then just ask them to give a really big cough, and you will then see some descent. And another really good thing for that is when you're assessing incontinence, if you ask them to give a big cough and they leak everywhere, that's quite a useful marker of probably quite significant incontinence. Bimanual examination is always useful to look for any pelvic masses or elicit any pain. And pelvic floor muscle assessment, I think if you felt comfortable to assess for this, that can sometimes be quite helpful to see if women are squeezing their muscles correctly. This picture on the bottom there is showing someone assessing pelvic floor muscle strength. So again, kind of parting the labia with one hand, putting 2 fingers in the vagina and asking the woman to squeeze their pelvic floor muscles. And if they've got really strong, intact pelvic floor muscles, your fingers will lift, you'll feel your fingers being squeezed around. And if they can't contract the pelvic floor, you won't feel anything. And here's just a couple of pictures. The first picture on the left is showing a prolapse. This is what we would determine to be a stage 2 prolapse. So it's coming basically to the hymen. You can't tell from this picture if it's the front wall, so a cystocele, a rectocele, which is the back wall, or if it's the vault of the vagina, if they've had a hysterectomy. But as I said, it doesn't really matter when you're doing an assessment in terms of referring through to someone. Just kind of knowing where it comes to is really useful information for us. The picture on the right, I don't know that it's come out terribly well, but this is a picture of quite significant atrophic change within the vagina. So you can get kind of some pale areas of the mucosa, some kind of erythema, sometimes some little petechiae, quite a kind of irritated looking vagina. And you know, particularly in a woman who has symptoms of incontinence, particularly urge incontinence, treating this with estrogen cream can be beneficial. And just some other things that you might kind of come across. The first picture on the left shows a very large urethral caruncle. So this is kind of an eversion of the posterior kind of lip of the urethra, as opposed to a urethral prolapse, which is a circumferential prolapse of the mucosa, which is what the other two pictures are. And the middle picture shows a woman who's got quite a significant, what we call a stage 4 uterovaginal prolapse, or prostodentia, where the whole vagina is effectively everted. In terms of investigations, some simple investigations that you could do would be a urinalysis or MSU to rule out an infection, look for hematuria or sterile pyuria. A bladder diary is also a really useful thing to ask patients to complete. And you can get a lot of these kind of online. So really just asking patients for 2 or 3 days in a row, preferably, to record every time they drink something, what they're drinking, what volume they're drinking and what time, and then every time they pass urine to measure it and document what time it is and the volume. And then documenting if there was any urgency associated with that void, if there was any leaking with urgency or with activities. And this can be quite useful to kind of establish particularly fluid intake. And this can actually be quite helpful for women. When they fill this in, they kind of might say, oh, I didn't realize I was drinking so much coffee, or, oh, I'm getting up at night a lot, but I see I'm drinking kind of a litre of fluid in the 3 hours before I go to bed. And sometimes it can be quite a good tool for women to kind of look at their fluid habits. But also you can also provide some simple advice with regards to cutting back on caffeine, maybe cutting back on fluid volume if that looks like that's a problem. The volume of urine that they pass can be quite useful. If people are passing really small volumes frequently, that can be a sign of kind of an overactive bladder condition, and they may benefit from anticholinergic medications whilst you're awaiting, or as part of their kind of management plan. And a pelvic ultrasound scan is always worth considering if there's a sudden onset of symptoms or if there's any concern with pelvic mass, obviously on examination. So in general, most patients that you see will probably have fairly straightforward urinary incontinence, so stress incontinence, urge incontinence, or mixed urinary incontinence. But if people don't really fit into any of those categories, or there's something else going on, then it's worthwhile referring through for specialist review kind of early on in the piece, rather than trying to manage this conservatively in the first instance. So this table here comes from some Australasian guidelines on kind of management of the non-neurogenic overactive bladder. And they're things to really watch out for that would prompt a specialist referral. So kind of red flags, if you like. So kind of hematuria, recurrent UTI, sterile pyuria, nocturnal incontinence, lifelong incontinence, significant obstructive symptoms, any neurological symptoms. And then if you find an overdistended bladder on exam, neurological deficits, evidence of malignancy, but also taking into account their surgical history. So any past urological or incontinence surgery. And again, just reiterating that if they have had mesh, then please refer. Also any history of radiation or neurological disease. And also I just suggest if they do have a significant prolapse, or there's any concern of a fistula or adolescent incontinence, then also this would be worthwhile referring through. So if we look at urinary incontinence as a whole, so we can divide that into kind of complicated incontinence, which is those things that I've just talked about, which need a referral. And uncomplicated incontinence. So for standard kind of stress incontinence, urge incontinence, mixed incontinence, the two main modes of conservative management are lifestyle changes and pelvic floor muscle training. So if we're talking now about stress incontinence management, first of all, it would be worthwhile to provide advice on lifestyle changes and fluid management. And then really one of the first things you should be thinking about is referring through to a pelvic health physiotherapist or a continence nurse specialist. And these are specialists who can teach your patients how to work on pelvic floor muscle training, and maybe also able to offer continence pessaries, which we'll kind of come back to a little bit later on. But if a patient has bothersome stress incontinence and has not responded to conservative measures, then that is when it's worthwhile referring through for specialist review to consider further treatment. And so with that, I'll pass over to Helen and Shelley to talk a little bit about their management of patients.
Kia ora, ko Shelley Solomon tōku ingoa. Hi everyone, my name is Shelley Solomon and I'm a pelvic health physiotherapist. Pelvic health physiotherapists are qualified physiotherapists with a special interest in pelvic health and pelvic floor muscle function and dysfunction. And we have postgraduate training and qualifications in pelvic health. So it's not something that you come out of physiotherapy school trained to do. And I think we probably differ the most from our other physiotherapy colleagues in that we're trained to do vaginal and rectal examinations. So historically, we only treated women for continence issues, pre and post-op gynae, prolapse, and then, you know, during pregnancy and postnatal. And we're often called women's health or continence physiotherapists. But in more recent years, we are treating people with bowel dysfunction, acute and chronic pelvic pain, sexual dysfunction, men, children. So most of us now either go by pelvic floor or pelvic health physiotherapist. Where to find us? I think best to firstly check your health pathways for your area, just to see. Also, there is pretty much a pelvic health physiotherapist in most whatu or hospital physiotherapy departments throughout the country. There are also private community physiotherapy clinics. Some of these are solely pelvic health physiotherapy, and then others there'll be pelvic health physiotherapists working in your more sort of general physiotherapy practices. So my advice is really to, you know, find out who's in your local area and just see what's available from a public and private option there. And then something, just a little tip, I've had probably over my career a number of GPs and other primary care sort of health professionals come and sit in with me. And I think this is something we would definitely, most of us would definitely welcome. So, you know, it may only be a couple of hours or a morning, but, you know, do feel free to find out who's in your area, just to find out what it is we do and find out that we're a lot more, even though we're talking about pelvic floor muscle training tonight, we're a lot more than just teaching pelvic floor muscle exercises. So I'll hand over to Helen now.
So hello, my name's Helen Peake and I hail from Invercargill. I've been a continence nurse specialist for about 18 years, and I do apologise that I cannot get my camera working. So like Shelley, these roles, the nurse specialist roles, involve a lot of postgrad study up to master's level often. So my population base starts at age 4. It covers both men and women, and both bowel and bladder management as well. And I always like to say that there's more to treating incontinence than just putting on a pad. It's about finding the why, how, and what can be done to manage this. And so we also do comprehensive assessments to find out what's going on, do physical examinations to identify the type of incontinence, and then we can implement a good management plan from that. We see a lot of men pre-radical prostatectomies, working with a lot of children, and certainly work with a lot of fecal incontinence. I find that these roles, you have to be a really good salesman, as you need to help people understand what's going on, and you really need to sell the conservative measures to them. And it makes such a big difference to people's lives. You know, when we get this right, and we often do, it turns their lives around, and people start to get their lives back, or be start to go out again, or be intimate with their partners. There's so many things. I'd estimate about 60 to 70% of the people we see are either cured or significantly improved by the strategies that we implement. My personal record is a wee lady of 93 who presented with both stress and urge incontinence, and by using all the strategies, understanding her pelvic floor and all of those things that we do, got her completely dry, which is awesome. So lifestyle changes that we would work on for stress and incontinence, there's been a lot of research to show that conservative management is first line option for most patients, as these strategies are effective, they're well tolerated, and they're safe with proven efficacies. Our goal is to actually stop the incontinence. That's our chief goal, thereby preventing any need for surgery. Often making the simple lifestyle type changes can have a significant impact on bladder management, but It needs to be taught well, and the patient needs to be supported and encouraged throughout their journey. If the strategies are not well taught and explained, and the patient has no gain or any benefit from them, it's very hard to try and get them to re-engage again at a later date. And probably the top of my list is managing constipation, because I'm really amazed at how many people are constipated or have real problems to empty their bowels. And of course, with that constant ongoing straining to try and empty puts real pressure on the pelvic floor, which doesn't bode well with stress and incontinence. So it's really important to explain the correlation between that and finding out what's going on. And constipation is usually a reasonably easy thing to manage. Encouraging people to lose weight is a modifiable and reversible risk factor. Being overweight can result in stress leakage because of the increased intra-abdominal pressure, which again puts pressure on the pelvic floor and puts a constant strain on the pelvic floor. I read one study recently that said that a 5 to 10 kilo weight gain can increase the risk of incontinence by nearly 50%, which is massive. Conversely, a 5 to 10 weight loss can significantly reduce the level of incontinence. Smoking is another risk factor, which relates to an increase in coughing episodes. Once again, it puts pressure on the pelvic floor. And people often tend to roll their eyes when you ask them how much coffee or how much caffeinated type fluids they have. Caffeine is a diuretic plus has an irritant effect on the bladder. And excessive fluid intake can exacerbate the symptoms of stress urinary incontinence. And there's a lot of people who overhydrate, as Niki alluded to earlier, and it's not uncommon to see people who drink anywhere between 3 to 5 litres a day, which is excessive, especially for those who aren't undertaking strenuous exercise or who are not living in very high temperatures, as in this very cold in Chicago tonight. So of course, drinking about 1.5 to 2 litres is a recommended fluid intake. People who drink a lot put higher volumes of fluid in their bladders, so when they leak a lot more. Helping people to understand their lifestyle, people who have occupations with heavy lifting or who put repetitive strain on their pelvic floor can be a real factor for incontinence. So just helping them to re-look at how they go about doing things or what they do. And of course, a big key thing in our lifestyle changes would be understanding the pelvic floors.
Thanks, Helen. Pelvic floor muscle training is also a very successful conservative option for the treatment of urinary incontinence. In fact, there's really, really good evidence that supervised pelvic floor muscle training should be offered as first-line conservative therapy for women of all ages with urinary incontinence. The 2018 Cochrane review on pelvic floor muscle training for urinary incontinence, they found women with stress incontinence who completed pelvic floor muscle training were 8 times more likely to report cure compared to those with no treatment. And then women with any type of incontinence who completed pelvic floor muscle training were 5 times more likely to report a cure compared to those with no treatment. And I think it's important to point out it's not just giving a handout to a patient and sending them on their way, although we do appreciate that this is better than nothing, and I know you have very short timeframes with your patients, so this may well at least get them started. However, to get the best results, and again, the research is really, really clear on this, pelvic floor muscle training needs to be taught and supervised, preferably by a pelvic health physiotherapist or continence nurse specialist with experience and skills in this area. Correct technique and having awareness and being able to isolate the correct muscles is vital. We use a lot of imagery and various cues can be really helpful. Squeeze the anus or squeeze the back passage. Imagine you're stopping the flow of urine are two of the most common ones. There are many others as well, some of them quite creative. But it's really important that you get the right muscles are targeted and that there is minimal accessory muscle use or movement. And I often say to patients, we can both be sitting here now doing our pelvic floor muscle exercises and the other one doesn't know. So that's really important they get the correct technique. As far as timeframes go, again, I say to my patients, 3 to 6 weeks of pelvic floor muscle training to notice a difference, but it's 3 to 6 months to get to full strength. And it doesn't need to be every day for the rest of your life. Pelvic floor muscles are skeletal muscles and they can be trained in the same way as other skeletal muscles, and then it's a maintenance program after that. Compliance and adherence is the most common downfall of pelvic floor muscle training. However, referring to us, the likes of Helen and I, physiotherapists and continence nurse specialists, referring to us early helps hugely. There also are various sort of adjuncts. There's different apps out there that people can use. Squeezy is a really well-known one from the UK, an NHS one that people can download. There's also biofeedback equipment, the FemFit, PeriFit, PeriCoach, LV, you'll hear all manner of these things. Also balls and weights, they can be really great for the right person. Again, I'd suggest contacting your nearest pelvic health physiotherapy therapist for advice and guidance on this. If you or a patient are interested in learning more and finding out what's best for them. And then stronger pelvic floor muscles not only help with incontinence, but also have a part to play in sexual response and awareness and better sexual outcomes. So this could be an incentive for some patients. So we would strongly encourage you to either refer your patients or encourage them to visit a pelvic health physiotherapist or continence nurse specialist with skills in this area, as pelvic floor muscle training really, really does work for incontinence. And the earlier patients start this, the better. Like Helen said, pads are great, but there's so much we can do early on, and the earlier we get them, the better results we have.
So I just wanted to talk a little bit about continence pessaries. So for stress incontinence, we would often recommend lifestyle changes. Pelvic floor muscle training is discussed by Helen and Shelley. But then another conservative option that we have are continence pessaries. So these are like the pessaries that we use for prolapse, but they have this little kind of knob on the end, which sits just underneath the proximal urethra and the uretero-vesical junction to really kind of stabilize the bladder neck. And this is something that we can teach women to insert and take out themselves. And this can be quite useful particularly for young women who find that they only leak, say, when they're going for a run or when they're playing netball. And this is something that they could put in and then take it out again afterwards. So studies have found that approximately half of women find it an acceptable form of therapy. The ones on the left there are the ones that we commonly use in our clinic settings that we will fit women with. The two pictures on the top right are of a device called a Contiform device, which women can actually purchase online. And it comes in kind of a fitting kit where you get the 3 different sizes and you work out what size works for you. And then these can be reused over a period of time, and then you can just order more of the size that works for you. So again, this can be useful and again, often quite good for women who just need it for when they're doing activity. Studies have shown that actually just using a tampon can actually improve continence, and certainly we have women who will say that while they've got their period, actually their leaking isn't so bad because they're using a tampon, and it's doing the same thing. It's providing that support to the bladder neck to really help with that urethral hypermobility. So continence pessaries are something that we, that urogynecologists, urologists and gynecologists can often fit. Some continence specialists and physiotherapists can also fit women with these pessaries, but not all. So it kind of might pay to find out what your local providers are able to offer if this is something that your woman is interested in. And so when we have women who have tried everything, so they've really maximized conservative therapies, but they're still really bothered by stress incontinence, and they want to go ahead with further management, we would usually perform urodynamic studies to really ascertain kind of what kind of pressures are required within the abdomen to make them leak. We are wanting to also know particularly what their voiding is like. If their voiding is not great, we may make that worse with a stress incontinence procedure. So there's quite a few things that we look at when we do a urodynamic study. And in terms of surgery, there are 4 surgical options that we have, and I won't go into too much detail about these, but we have a fascial sling, which is a sling that is made out of the patient's own tissue, commonly the rectus sheath, or sometimes a fascia lata from the thigh. There's a synthetic mesh midurethral sling, which is placed in the same way, but uses a synthetic permanent mesh. We have urethral bulking, which is where we inject a substance into the urethra to provide support from within. And also the Birch Colpo suspension, which is an abdominal or laparoscopic approach where sutures are placed either side of the urethra to elevate the urethra internally. A thorough informed consent process is required for these procedures, particularly if mesh is being considered. Each procedure has its different kind of risks and benefit profiles. Not all areas are able to offer all of these procedures either. And at the moment, the Ministry of Health are undergoing a credentialing process to ensure that surgeons who are performing these procedures are appropriately educated and trained and are able to identify and manage complications as they occur. So, and that kind of brings us on, I just wanted to touch briefly on complications of incontinence treatment. So anyone who has surgical intervention, there's always a chance that they may have a complication from the surgery. This may present years after treatment, and this could be with a mesh or with a non-mesh procedure. We do see complications from Birch and fascial slings. So possible ways that this may present could be vaginal bleeding or postmenopausal bleeding, pain or sexual dysfunction, persistent urinary incontinence or new incontinence, voiding difficulties, recurrent UTIs, retention, long-term catheter use, and sometimes people are unhappy with the treatment or the outcome that they've received. And so in any of these situations, if you have a woman who presents and they have any possible complication from an incontinence treatment, please refer them through for specialist assessment so that we can work out how best to help these women. And I'll hand back over to Helen to talk about conservative management of urge incontinence.
Thanks, Niki. So urge incontinence is quite different to stress incontinence, whereas stress incontinence is more of a support system failure, i.e. the pelvic floor. Urgency is more the overactive, the trusor muscle, and it can be really debilitating for a lot of people who suffer that. One of the first places I look is dealing with people who once again are constipated, because it can have a real impact on how the bladder behaves. If you've got an overloaded, constipated bowel, it puts pressure on the bladder neck that can cause the trusor to fire spasms all the time with that ongoing urge to void, which can be really debilitating. And managing constipation can make a really, really big difference. But it's I find it's important to tell people that getting your bowel under control is not a quick fix. It takes a bit of time, and for some it can take months. Once again, good obesity can certainly aggravate the bladder and cause incontinence just with the sheer extra volume of weight. But it's also can be the practical things like someone who's really obese struggles to get themselves off a chair or to walk to the toilet or be able to fit in to the toilet or do what they need to do in there. So encouraging weight loss can be really important, but once again, it's not an easy thing to talk to some people about. Nicotine and associated toxins can be very irritative to the bladder. Once again, I talk to people about how much fluid they drink and what type of fluid they drink. But it's interesting that a lot of people who have urge incontinence or urgency actually stop drinking or cut their fluid intake right down. It's not uncommon to find people only have 1 or 2 drinks a day. And of course, concentrated urine in itself can be a real irritant to the bladder. But other things like tea and coffee, anything with bubbles, alcohol or artificial sweeteners are also known as bladder irritants. And often when you're talking with people, they'll identify that themselves. They'll say, gosh, if I have a flat white or whatever, my bladder really makes me pay. So it's just about them understanding the correlation to that. And nocturia can be such a complex condition, which can be really debilitating for some people, but just simple management strategies that can be really useful. You can help people to get more control over their bladder using deferment techniques during the day. So once again, our goal is to reduce how often they go to the toilet, but increase how much they void at each time. Can have a rollover effect to how the bladder behaves at night time. Plus the timing of their fluid intake. So having the drinks in the morning or early afternoon can give the kidneys time to get things sorted and get rid of it before they go to bed. Avoiding caffeinated drinks after tea. But sometimes for those people who are on furosemide, which only has a 4 to 6 hour life, can be really helped if they actually change the timing of that to take that about 4 to 6 hours before bedtime at night. So it causes a big diuresis. They get rid of a lot of fluid before they go to bed. It can have a huge benefit for some people, but I find that a lot of people are a bit nervous if the doctor has asked them to take it in the morning. So I have to be very reassuring and say it's safe to change the timing of that, and that they're not going to get into trouble by doing that. And of course, making sure that that any medical conditions are well managed makes a big difference. People with diabetes is a significant risk factor for overactive bladder due to the detrusor instability. And this becomes worse depending on the severity of the diabetes and with the natural aging process. It's one of the most common and most bothersome complications of overactive bladder is poor glycemic control. It also increases the incidence of nocturia. And so what happens is that there's often a decreased sensation of bladder awareness, increased bladder capacity, but poor emptying. So a lot of these people can have high residuals, which again exacerbates the overactiveness. It's really important to encourage good blood sugar control. Overactive bladder and urgent incontinence can be very common with people with congestive heart failure, and once again incredibly debilitating. Not only are they breathless with the congestive heart failure, but constantly needing to go backwards and forwards to the toilet or being where it can be really hard for them. Already discussed the timing of the diuretics, but sometimes encouraging people to sit with their feet elevated can help reduce that lower limb swelling, gives their kidneys a chance to get rid of it before they go to bed. Because I explained to them, this is what happens when they go to bed, their feet are elevated. And so it's they're trying to get rid of a whole lot of fluid overnight, and so it exacerbates the nocturia. Compression stocking therapy can also be useful for these people. And there's such a direct correlation between sleep apnea and nocturia, and it's thought to be related to the hypoxia induced by the sleep apnea, which results in negative pressure breathing, which leads to a peptide secretion, which increases the nocturia. Interesting stuff, really. When someone comes in to see me with nocturia, I usually ask them if they snore or if they're an insomniac, and I give them a sleep study form to complete and refer quite a few of these to the respiratory team, because they can be really helped with CPAP therapy.
Yeah, look, I think urgency and urgent incontinence patients, we love seeing these patients. Well, we love seeing all our patients, but we can make such a big difference in a short space of time with these patients. So along with the lifestyle modifications that Helen's chatted about, there's some retraining that we can do. So firstly, behaviour retraining is really effective and a very important part of management. It's an intervention that reduces that sensation of urgency and to regain control over the bladder. So they've got that aim of making it to the toilet dry. The instinctive response to that sudden sensation of urgency is to rush to the toilet. But this really only adds more pressure to the bladder, increasing their chance of incontinence. Some other behaviours, such as breath holding, can also exacerbate that detrusor overactivity. So it really is a case of the more you rush, the more you leak. So patients can be taught calming techniques or urge suppression techniques, and there are quite a few of these. Just a couple. One of them is perineal pressure. Obviously, you can only really use that depending on where you are, most adults. Calf contraction is one, or toe flexion is another one that can be really effective. They're really effective strategies to try and control that and manage that urgency. Trigger retraining. So certain triggers can cause detrusor contractions and urgencies sorry. One of the most common is key in the door. So that sudden urge to go to the toilet as you pull up the drive, or you try and get your key in the door. Is a really common one. So we can retrain the bladder by retraining our response to certain triggers. And then bladder retraining is also often required, and this is where we need to increase that functional capacity of the bladder to decrease the frequency, the number of times they're going, to try and increase their volumes. And timed bladder voiding is one way of doing this. Pelvic floor muscle training, as we've previously mentioned, is also very, very effective for managing incontinence, and it's certainly part of the management plan for those with urge incontinence. We might look at avoiding assessment and bladder emptying, may also need review. And then if prolapse is contributing to their symptoms, a pessary may help with this and their emptying problems. And then the evidence for use of adjuncts such as tibial or sacral nerve stimulation, or TENS, is also improving and can be really, really effective in this patient group, as well as percutaneous tibial nerve stimulation. So, I'd encourage you to find out who's doing this in your areas, as they can be really successful for the management of these patients. Some pelvic health physiotherapists, continence nurse specialists, and obviously some gynecology and urology clinics do this as well. So definitely worth finding out who's doing it for this group of patients. So lifestyle modifications, retraining of behaviours, triggers, the bladder and the muscles are all really, really effective ways to manage urgency and urge incontinence. And again, we'd encourage you to refer to pelvic health physios, continence nurse specialists that work in these areas. Like I said at the beginning, we love seeing these patients because these conservative measures can really be often all that is needed.
So in terms of medication that you could start your patient on for urge incontinence or overactive bladder, is women, you can start them on estrogen cream or Vestin cream. And I think most of the referrals that I get, patients have had some treatment. So I'm sure that, this is not new to you. And it certainly helps with urinary urgency, frequency, urge incontinence, and also prevention of urinary tract infection. Now, the other two drugs, which is oxybutyn and solifenacin, they are funded options. So many of you are aware of these medication, and often we do see patients that have already been offered this or have failed this treatment before we see them in specialist clinic. Now, just to reiterate, some of the contraindication for using antimuscarinics is really acute angle glaucoma, and the commonest side effects that patients do get is dry mouth, dry eyes, and constipation. Now, I will speak a little bit more about the cognition change with patients on anticholinergics in my next slide. But basically, these are usually first lines or, medical treatment following failure of your conservative management, or I'm very happy for you to start this at the time of your referral to have their pelvic floor muscle training. Now, mirabegron, most of you may not have heard about this drug or know that this drug is available in New Zealand. It is not widely available. There are certainly some pharmacies in Auckland that are importing this drug. So so you may have to find out in your local pharmacies if the pharmacies are importing this in for patients. You can prescribe this drug to your patients. Currently, Pharmac hasn't given this approval, and therefore it is definitely not funded. It is expensive. The cheapest one that we could get in Auckland is $125 per month, and some online pharmacy could supply it at $165 per month. Certainly, this drug has less side effects like anticholinergics, especially in terms of the constipation issue and problems with the dry eyes and dry mouth, and certainly less problematic with cognitive change. But their patients' blood pressure does require monitoring, because that is one of the commonest side effects, which is increase in blood pressure. So patients that have failed mirabegron, combination therapy between anticholinergics and mirabegron are actually not any better than on mirabegron alone. Now, why do our patients have poor compliance to anticholinergics? You might find that you've started patients on solifenacin, but they don't stay on it. So generally, I say to them, 70% of patients will stay on them for about a year, but or less. Sorry, 70% will stay on them for a short while. But at 3 years, you would see 90% of patients are no longer on them. Now, generally, this is due to the side effects. And a third would be due to the medications no longer helping their symptoms. So again, I stress that it's really important that you start the pelvic floor training, you start the bladder retraining at the time of starting this treatment, because what I usually tell my patients is if you have combination therapy, which includes conservative management plus medication, you would hope that within the first 3 to 6 months, we can take them off the drugs, or they no longer need the drugs because now their pelvic floor muscles are a lot better. They know the strategies to control their symptoms. Now, some of these stats are not really from New Zealand, but what I just want to draw your attention to is unrealistic expectation of treatment. I think that's really important. So if you want patients to stay on treatment for the duration that you want them to be on, it's really important to tell them what we're expecting. So a patient that has got, say, bladder pain with overactive bladder, you must say to them, these are not pain medications. So it's really not for pain. It is really to help with urgency or urge incontinence. Or you have to warn them of all the side effects that may happen, the dry mouth, the dry eyes, the constipation. So if you let them know and try and educate them to minimize the side effects, you may get them to comply with medication a bit longer. Now, this is really important. We get more and more reports about anticholinergics. This is your solifenacin or your oxybutynin, giving problems to the elderly population. So as if we remember the slide that Niki showed earlier in the presentation, we get more and more patients with overactive bladder as they grow old. So 50% over 75 would have problems with overactive bladder. And we do see our older generation being on anticholinergics up to more than 37%. So a lot of older generation people are on this because they've been put on for their overactive bladder and never get reviewed. So some of these trials that I've gone through, this is the conclusion. So if you are if you're starting an older person, I'm talking about 65 and above, all right, on anticholinergics, I would suggest that you try them on only for 4 weeks, all right? Give them the first prescription for 4 weeks, warn them of the side effects. And if they're at risk of dementia, or you feel like they've already got some mild cognitive impairment, don't start on anticholinergics. I think it's a bad idea. But if you feel like they're in their 50s or their 60s, that they're fit and well, and that they understand the side effects and they're willing to try, you can put them on 4 weeks, and then see them back in 4 weeks to see if they've got some improvement while they're on anticholinergics. If they haven't got any improvement in 4 weeks, then there's no reason we should continue on that treatment, putting them at risk of dementia. Now, most of the clinical studies, we don't have people who are on anticholinergics for more than 3 months. So I actually don't know how long the efficacy of anticholinergics would actually last. So again, we must put them on lifestyle changes, pelvic floor, bladder retraining, because my aim is to get them off this anticonvulsive as soon as possible. Now, there are large observational studies that show that you can increase the risk of dementia up to 20% if you are putting them on long term. Okay. Now, one good take-home message is, if you have put them on and you feel like they are losing their marbles, right, you can stop them, and it should be reversible. So it is quite important when you put them on anticholinergics that you do organize a follow-up to see if and to warn them or their family that the medication that you're starting them on, they may get more disorientated. They may lose some memory. So if they have noticed that, then that can be stopped, and the effects should be reversible. Now, this is also, especially for oxybutynin, I'm really hoping that you're no longer prescribing oxybutynin, especially in the elderly population, because not only they can cause dementia, it can also cause delirium. So if you have older people that has gone to hospital for delirium, please review their medication chart. If they are on oxybutynin, please stop it. And sulfasalazine, again, I would say, if you want to try them on a short term, 4 weeks, that's fine, but do review them. And if it's not giving any side effects, if it's not giving any effective bladder control, then stop that medication. But if it is making a difference, then you can talk to them about short-term use, being very careful, or if they can afford mirabegron, which is a lot more expensive. Now, tertiary management. So if they have failed their conservative treatment, they can't take medications, or the medications have failed, then refer them on to us. And in hospital, we put them through urodynamics, which is a bladder testing, to confirm that the bladder is going to be safe for us to introduce the next step of surgical management, which generally will be intrathecal Botox injection. And 80 to 90% of patients on Botox very satisfied with that. But up to 2 to 5% patient can go into retention, which requires short-term catheterization or intermittent self-cath. Now, the options that we have talked about earlier about sacral neuromodulation and PTNS, they are not widely available, very expensive, and it's not funded in the public system. So some very limited insurance company would fund this if your patients have insurance, but certainly these are options that at least they don't put people in retention. Okay, and sacral neuromodulation, the efficacy is about 70%, and PTNS at about 60 to 70%. So, but very expensive. I can talk more about this in the question Q&A if you're interested. And in terms of salvage options, they are available. Augment, in my practice, I probably do 1 augment a year. I certainly know certain other specialists may do more, but in New Zealand, it is still an operation that's not offered a lot, and since Botox has worked so well, we've done less and less augment, to be honest. Mixed urinary incontinence, if you remember the diagram I showed you before, it's about 30% of patients with incontinence has got mixed incontinence, so it's quite common. So generally, how do we treat if you've got mixed? You're never going to be wrong if you start treating urge, okay? Because most of your urge incontinence treatment is reversible. You can stop the medication, the Botox will wear off. So, that's always a safe option to go for if you're not sure. But generally speaking, it is you try and treat the most bothersome symptom, because if you remember the diagram I showed you before, they can have 80% stress incontinence. That's the majority of their leakage, and they have some frequency and urgency, but not really causing any incontinence. So that would be a little bit unfair to give them treatment on urge when their problem is majority stress. So do treat the most bothersome symptom first, but if they have almost equal 50-50, then treat the urge, because that is a reversible condition if you feel like the treatment has given them side effects. Now, this is just to recap. I just don't. I think we've gone through a lot of most of these already. I just want to point out a few things. If they have failed conservative measures, refer them on to us. And in hospital, we do more assessment, especially urodynamics, to try and ascertain their bladder function and talk to them about further management. And when you refer them to us, it does not always mean that they're going to end up having surgery, but certainly surgical options will be discussed. Now, we, as a group, we were thinking about your 15-minute consult. And, you've listened to us for more than an hour, but, tomorrow when you go back to your clinic and you might see a patient, you're thinking, well, how do I cram all this thing in 15 minutes? So this is my attempt to see if this could help you in your conversation with your patient tomorrow. So 3 easy questions to begin with, to try and differentiate whether this is stress, urge, or mix. So question about, do you leak with coughing, sneezing, or running? So if they're more likely if they say yes to that, it's more likely to be a stress incontinence. And then second question that I often ask, if you get an urge to go to the toilet, would you leak on your way there? So if they say yes, okay, they've got an urge component. Now, if they have more problems at night than during the day, they're more likely to have overactive bladder. And then, like what Niki has said, it's quite important to know the severity. So how does that affect their life, in terms of number of pads they use, or are they restricting their fluid so much? Like Helen had said, that, they're drinking so little to try and stop themselves leaking. Or patients that used to be really active and has now sort of stopped doing a lot of stuff just because of their leakage problem. And then the red flags that Niki has given us a slide about, that's quite important. So if you think that these are not straightforward incontinence issue, do send them to us early, because the last thing you want is to have someone sitting at home with a fistula that you're trying to wait for physio. I think that has definitely happened to one of my patients, and I really hope that we do better in this. Now, examination, again, we can, 3 important things to find out. Is does the patient have atrophic vaginitis? If they do, start the Ulveston cream. If get them to cough, if they cough and they have a leak while they're lying down when you're examining them, most likely they have got significant stress incontinence. And also, while you're doing that cough test or the straining, the 6-second straining that Niki talked about, again, if you see a prolapse coming out of the lower than the hymen or the introitus, you can at least tell us how many centimeters out, to give us an idea if the prolapse is significant or not. Now, in terms of management, conservative as much as you can. So that includes bladder training, pelvic floor, fluid and weight management, which you should stress when you see them. And then in terms of medication, really only very few. So we're surgeons, there are not many medications we can play with. Ulveston cream, local treatment, or you give them anticholinergics, solifenacin, and if they can afford mirabegron, we can talk about it later in your Q&A. So that's probably the only medication that we talk about. And I appreciate Helen talked about I think there's a question about furosemide. And that is certainly something I use as well. If I think patient has got nocturnal polyuria. Okay, so if you want to talk a little bit more, we can talk at the Q&A. But more importantly, after your 15-minute, 14th minute, you're thinking, okay, how are we going to follow up on this patient? If you start on solifenacin, please see them back in 4 weeks. Otherwise, refer them on to a continence specialist or pelvic health physiotherapist. Or if you think they need an early referral to us, please send them through to us. Now, one thing that I forgot to put in some of my slides is, if you have an elderly patient that has a new onset of overactive bladder, or a new onset of urge incontinence, or a new onset of nocturnal enuresis, please think about possible bladder cancer. Okay, and I've seen this happening at least once or twice a year. So if you're unsure, do your urine test to see if there's microscopic hematuria. If you're still not sure, do a urine cytology to see if they've got any positive cytology, so that we can see them sooner. Now, these are helpful resources, and I think this will answer some of the questions that you have put in our Q&A box there. So the Health Navigator provides very good information for patients to read, and there are local health pathways which are available to you. Most of you have, you will have local pathways, except for Hawke's Bay, and I think Midland is actually developing their own. But otherwise, GPs in those two areas have access to a Canterbury pathway. Now, Continence New Zealand website and Physiotherapy New Zealand website has got very useful information for you as well. And personally, I think Niki and myself, we use the IUGA website a lot to talk through our management with our patients. So that's also available that you can actually access.
We do just have a very few quick slides just talking about expansion of ACC cover to cover maternal birth injuries. So this is very exciting development. It's only really become live this week from the 1st of October, and these slides have been provided to us by ACC. But effectively, there's been an accident compensation, maternal birth injury and other matters amendment bill, which has been passed into law in late September. So these changes are now effective from the 1st of October. And basically, this is on the basis that we know that up to 80%, if not more, of birthing parents may experience an injury. And some of these parents will need further intervention and help. So there's quite a big list, actually, of things that are covered now. So it's all these things on the left there. So it covers prolapse, levator avulsion, which is a common injury that occurs with birth, any obstetric anal sphincter injury, tears to the perineum, and then the more kind of the rarer things, so fistula, hematoma of the pelvis, pubic rami fracture, ruptured uterus. So I guess the main things to know about this are that this cover is not retrospective. It can't be applied to any injuries that occurred prior to the 1st of October this year. Cover can be considered for mental or physical injuries caused by a listed maternal birth injury, and claims must be for a diagnosed birth injury, not just a symptom such as urinary incontinence. And this does not cover injuries to babies. In terms of lodging claims, GPs and other healthcare providers can lodge these claims. Midwives can also now lodge claims within their scope of practice, which is fantastic. And there's a range of services that may be provided to these parents. And there's some really good information on the ACC website for both healthcare providers, but also for parents, so that they can see what they can seek help for, what's normal after birth, what's not. And that's a really good place to go. So it's really early days. This has just come out. We're very excited to see how this is going to pan out for parents. Yeah, very early days. And that's us, I think. So we're happy to answer any questions in the remaining minutes that we have.
Thanks so much, guys. And yes, I think if you're okay to stay on a little bit longer, we'll go through a few of the questions that are coming through. And yes, I'm sure the ACC cover will be lots coming through around that as well. I think sometimes about to answer a couple here around the Botox, and if you don't mind speaking to it, was around how long does it last for and can it be repeated in the treatment?
Sure. So Botox, we usually say about 9 months, but it can really vary. Okay, can vary between 3 up to 12, but recently I've got a patient who has had 19 months. So it varies. So usually we say about 9 months. Yes, it can be repeated. So usually after the first one, if they have had a good effect, and that can be repeated when it wears off.
Brilliant, thank you. And there's a question around the continence pessaries and how long these can remain in situ. Are they always, you talked, I think it was Niki, you're talking about taking them in and out with specific exercise. Can they remain in situ and how long for?
Yes, they can. So with any pessaries that we use for prolapse, we for the standard ring pessaries, but also for incontinence pessaries, we can leave them in for kind of up to 6 months at a time. In a postmenopausal woman, we would usually advocate using estrogen cream, so just to protect the vaginal epithelium, to prevent kind of infections and erosions, but certainly they can stay in for kind of up to 6 months at a time. Some women don't want to know about managing it themselves, and some women really do. some pessaries, some women find that they can have intercourse with them in, and other women find that it doesn't work for them. So that can sometimes be a good reason for us to educate women on how to take them in and out themselves. And certainly the Contiform device, I think in general is one that's mostly just put in, say, for the day and then taken out. It can't stay in quite as long as the ring pessaries with the knob on them can.
Brilliant. And one more question around the pessaries. Do they need to be fitted and seen by a pelvic floor physiotherapist or by one of you guys, or can we measure it and do it ourselves? I think you mentioned that particular device that you could order online and do.
Yeah, and so, I mean, certainly anyone who is happy to assess and fit a patient for a pessary could do so. And I know some GPs do fit with pessaries. I'm not so sure about the continence pessaries, but it's very similar. The main thing is actually having access to the pessaries. And I know that that's not necessarily easy in primary care. We have a big supply, in the hospital system. So we try different ones. We have fitting kits. We can try all different shapes and sizes of pessaries for prolapse and incontinence. But certainly, and some physios are able to fit them, some continence nurses. And so if there were GPs that were wanting to learn, we're always more than happy, to have GPs come to our clinics, and we're happy to teach you how to do them. And sometimes actually patients would prefer to go to their GPs just to have them changed. And so actually just learning how to take them out, check for any erosions and put them back in can be a really useful skill to have. Yeah.
There's a couple of questions around Avestin cream, specifically how often, how much, and for how long, and a further question around its use in hormone receptor positive breast cancer, or I guess just any form of the hormonal cancers and Avestin.
So we normally get women to use estrogen cream twice a week. That's sufficient to keep the tissues healthy. If someone has quite severe atrophic vaginitis, they present for the first time and they have quite significant atrophic changes, often we would suggest using it once a day for a couple of weeks and then going to twice a week. Some women find that for maintenance they can use it less, so maybe once a week, with a pessary in place once or twice a week. In terms of safety, there's been some studies that have looked at, women who have had breast cancer, so estrogen receptor positive breast cancer, and their use of estrogen cream, and there does not seem to be an association with an increase in the risk of recurrence. So it is generally felt to be probably quite safe in this group, but it is something that, the data is not great. And so we do always talk to women, and often women prefer not to use estrogen cream if they have had an estrogen receptor positive breast cancer, understandably. In that case, we would often suggest that women use something like Replens, like vaginal moisturizer, which they can buy from the pharmacy. And you can use that kind of up to once a day. And that can provide some kind of moisturizing benefits for women who can't otherwise use estrogen. Studies have shown actually when you look at the serum levels of estrogen when you use the estrogen vaginal cream, that actually very little is absorbed. It doesn't, your levels are still nowhere near the levels of kind of a premenopausal woman. So very little of it is absorbed systemically. So that's why we think it's most likely to be safe in women who have had breast cancer.
Brilliant, thank you. And there's a question here from as a pelvic health physio, and Shelley, you might want to speak to this as well. But if you think of medication as of value for one of your clients, you can refer through to the GP for the prescription. And I certainly, as a GP, I think that's a really great way to create some correspondence and discuss and see what we can do together to help someone. Is that what you would normally do, Shelley?
Yeah, absolutely. Yeah, if we think so, we definitely refer them back. And again, it's about making those connections and yeah, definitely.
Brilliant, thank you. There's a question: if a woman has stress urinary incontinence and erectocele with obstructive defecation symptoms, can this be a direct urogynae specialist referral? Is that something that you would expect to see early on?
This would be what we commonly see. So we commonly, certainly in urogynecology, we see patients, they very rarely just have an isolated prolapse or an isolated incontinence. It's very common that we would see women who have They might have mixed incontinence, a bit of voiding difficulties, some sexual dysfunction, some prolapse symptoms, maybe obstructed defecation. So we kind of cover all of those things. So, and this is something that, again, there's a lot of conservative management here as well. These, a woman with, say, a rectus-seal obstructed defecation is going to benefit from seeing particularly a physiotherapist to talk about, Shelley can probably talk more about that, but, in terms of conservative, toileting positions and those sorts of things, as well as the management of incontinence. But certainly, this is something that we kind of manage the whole pelvic region, really, so we can manage all of those things.
Okay, thank you. There's a question here. Can you please expand on the comment around nocturia and frusemide?
Yeah, so I think that's when the bladder diary becomes really important, because that's when we calculate if the total urinary volume overnight is it's more than a third of the total urinary volume over 24 hours. So if you feel like this is a nocturnal polyuria, then it may get associated with overactive bladder. So or it may be this is the primary problem. There's no overactive bladder problem. This is purely a volume issue at night because of production of more urine at night, especially in the elderly population. Then they may not need solifenacin. So if you're thinking about solifenacin that's going to give them dementia, this is unlikely to help. But the problem is, if you want to treat that, you don't want to give an elderly patient desmopressin, because we all know that lowers their sodium and they can have even more problems. So I think getting the right diagnosis is important, and that's when the frusemide comes into place. So that is really just to regulate volume. We're not trying to treat the ADH. We're not trying to treat the overactive bladder. We're just trying to shift the volume of fluid so what I do is to give them frusemide at midday and try to get them to pee more before in the evening. So that's something that I often do, and which I think among the three medications, between oxybate, solifenacin, or desmopressin, maybe the frusemide will be lesser of the three evils, So that's what I could do, and it has been quite successful for some of these patients.
Brilliant, thank you. There's a few more questions around Avestin, and actually one of the things I noted on your early slides, Niki, that you were speaking to, one of the risk factors was around hormonal therapy. And can you speak a little bit more about that? And then there's a question around women taking HRT, oral HRT, and whether they can still use Avestin, which I think is still usable, but can you make a comment on that too?
Yeah, so systemic hormone replacement therapy is associated with an increased risk of stress incontinence. From some kind of those, a lot of studies in the 90s looking at hormone replacement therapy have identified that, which is interesting. So we know that can increase your risk of stress incontinence. Estrogen vaginal therapy is not likely to help stress incontinence, but it does tend to help with the urge incontinence. So I guess you're kind of using different things to treat different things. Someone who has stress incontinence would not be likely to get any improvement from hormonal therapies vaginally, and it may make it worse if they go into systemic treatment. Whereas for overactive bladder or urgency, then there's a good chance that they'll actually get a significant improvement with vaginal estrogen. I'm not sure about the effect of systemic estrogen on urinary urgency, but again, I think I don't think it's known to have a significant effect either way. Actually, it's really more the topical estrogen cream vaginally, which is known to be of benefit.
Okay. And the neuro preparations for hormonal replacement therapy, has that changed from the studies that you were done in the 90s that showed that evidence?
That's a good question, actually. I don't know of any more recent studies that have looked at the newer, like you mean like the patches and I'm not aware of any studies that have looked at that specifically looking at stress incontinence. No, I'm not sure if anyone else on the panel knows.
No, not that I am aware of. I mean, if you think about the pathophysiology for stress incontinence, I think, maybe not going to be a huge difference. If we're talking about support of the urethra and also, the coaptation of the mucosa, I think I can't see it being a huge benefit.
Okay. Thank you. And can Avestin be used in women who have had a DVT or a PE?
Very good question. I'm sorry. I certainly wouldn't have stopped people using it if they've had DVT and PE, because the systemic absorption is so low. And also I agree with what Niki said about if patient has had positive estrogen receptor breast cancer. I personally don't think I have a problem starting them on. I do tell them about the risk because my medical oncology colleagues start them on. So I've got, you know, a lot of confidence if both specialists think they are safe. Certainly, I think it's safe for them to start. But if some patients just don't feel comfortable, and we certainly, you know, don't want to force those patients on taking those treatment. But certainly, if they're open to it, I usually say have a chat with your med onc next time you see them, because I personally have no problems if you want to start them.
Thank you. Shelley, this might be a question for you. It's around a birth injury from a forceps delivery, where there has been damage or a tear of the pelvic floor. Are pelvic floor exercises still helpful in this situation?
Yep, absolutely, because it's not the whole one side of the pelvic floor that tears off, it's just a small part of it, a pretty significant part, but there's still a lot of other muscles there that can be rehabbed and things that we can do, definitely. So yeah.
Thank you. And there is a question around the urge incontinence management being useful. Is this useful for men with benign prostatic hypertrophy?
Sorry, I don't know, some of you are going to say something there, but yeah, I've certainly treated men with this successfully. So, yeah.
Brilliant, thank you. Yeah. All right, I think we probably have what time. There is, I don't know if there is a role for PRP in vaginal prolapse, but there is a question around that. Is there any evidence behind that, Niki or Simpson? No. Okay.
No, there's no evidence. There's no evidence yet. There's a few experimental trials going on in that sort of space, but we don't have any evidence for that yet. Just like laser has been shown not to be effective for stress incontinence or prolapse, vaginal laser therapy. Again, there's been an RCT, which I think has just been published from Melbourne, where they found no difference between laser and sham for stress incontinence. And there's also some kind of FDA warnings around the use of laser for urogynecology conditions. So we don't advocate the use of laser.
Right, thank you. And the last question, can you comment on around the use of prednisone and the risk with incontinence? There is a question around here, weaning off prednisone if you needed to, or what other management you could do with someone who is taking prednisone.
I'm certainly not aware that there is a direct correlation. I mean, feel free to correct me about prednisone creating incontinence or worsening incontinence. I think if I were to see this patient, I would do the basics first. Okay, do your urine test to find out the type of incontinence we're talking about. Is this stress, or is this urge, or is this mixed? The only thing I could think about, as I saw that question earlier, was I was hoping someone else would answer it, is that whether that prednisone was done for, what was the reason was the prednisone? Was it for cough, or was it for a lung issue or a breathing issue that there's a lot of coughing involved in this, or is there a lot of weight gain with prednisone being on for so long? Is this, just to try and ascertain the mechanism or the pathophysiology of creating incontinence? And if obviously there was a short-term use of this and the patient eventually is going to come off that, you can still treat certain things, right? You can still do your conservative management. And then, if there's urge involved, again, you could start them on, those medications, sulfenacin, oxybutynin, or mirabegron. And more importantly is when the patients finally come off that, I think certainly weigh the patient now and know what the baseline weight is, and while they're on prednisone, if they've been gained a lot of weight, and when they finally have lost that weight, do they go back to their baseline weight at that point and see if the incontinence continues to be a problem? Because at the end of the day, if this is a short-term thing and it's crucial for their health, if not, if they really need it, then this could be a temporary thing. But if it becomes a problem afterwards, despite going back to the baseline, then this could be an association. They were about to develop this, and this has just sort of somehow been associated with it. But I'm not sure, Niki, can you see a direct correlation with prednisone?
that I've missed out?
I'm not aware of a direct correlation, no.
Mm.
Yeah,
Okay.
great. Thanks so much, Samsam. And thank you, Helen, Samsam, Niki, and Shelley for all your wisdom tonight. It's been wonderful and lots of really practical tips for all of us in our management of people. So thank you so much, and we're looking forward to the next session with you all. Good night, everyone. Thank
Great.
you.
Thank you.
Thank you.
Thank you.
Bye.
Thank you.